dear colleagues and friends, very good afternoon to all of you. At the outset, I would like to extend my sincere thanks to Dr. Kilada and his organizing team for extending this kind invitation to me. Imaging plays a very important role in the diagnosis of pulmonary as well as extrapulmonary tuberculosis in HIV-infected patients. Imaging findings vary in this group of patients with respect to degree of immunosuppression. In present talk, I'm going to highlight some of the signature imaging findings in patients with tuberculosis by showing some interesting cases encountered in day-to-day clinical practice. TB is the most common co-infection in HIV patients in India. Drug-resistant tuberculosis is much more common among HIV-infected patients than non-HIV-infected patients. Unlike other opportunistic infections, which occur at very low CD4 cell counts, TB is unique in that it can occur over a wide range of CD4 counts. And as I mentioned, the imaging pattern of tuberculosis vary depending upon the CD4 count. Imaging modalities in pulmonary tuberculosis, diagnosed pulmonary tuberculosis, includes two important things. One is conventional X-ray chest and HRCT of the chest. Relatively inexpensive and freely available conventional X-ray chest still remains the primary screening modality of choice in the patients suspected to have chest tuberculosis. In vast majority of cases, you would certainly get an answer, but there are also limitations to conventional X-ray chest because of overlapping shadows and so on. And at tertiary care reference centers like ours, we now repeatedly doing high resolution CT scan of chest for better delineation and characterization of the parenchymal lesions. In extrapulmonary tuberculosis, the modality is available to us is sonography. That is considered to be the primary screening imaging modality of choice in abdominal imaging, followed by, of course, CT for much better depiction of the thoracic and intra-abdominal imaging. And for this, MRI is the modality of choice for central nervous and musculoskeletal imaging of tuberculosis. Now, these are two patients who have the CD4 cell count in the range of 250 or so. The case on left side shows a dense consolidation in the upper lobe of the left lobe. The rest of the right lung appears clear, while in the case on the right hand side shows a thick wall, a small cavity. Yes, thick wall cavity surrounded by the pulmonary infiltrates. And in addition, there is also blunting of the CP angle and considering showing the pleural effusion. Now, these are the very classical imaging findings of tuberculosis, and by and large, any patient who has a CD4 cell count more than 200 to 250, they have an imaging appearance more or less similar to that of immunocompetent patients. So you get cavitating nodules, you get the infiltrates, and also pleural effusion and sometimes mediastinal lymph nodes. This is, of course, another two patients where the CD4 cell counts in the range of 100 to 150. And this case on left side shows a fine, tiny miliary nodules scattered throughout the lung parenchyma, as we call miliary mottling, which is almost diagnostic on X-ray chest. While on the right-hand side, you see a little bit of prominence of right hilar shadow and little kind of widening of the superior mediastinum. That would indirectly suggest the possibility of underlying mediastinal lymphadenopathy. However, over a period of time, we have come to realize that the high-resolution CT of the chest, which is the multi-detector CT scan, can give you much better delineation and characterization of the parenchymal lesions. Not only it shows it better, but also it shows an excellent distribution of these nodules, whether centrolobular, penacinar, peribronchial, and so on. At the same time, it shows the mediastinal lymph node directly. Unlike in conventional X-ray chest, we measure subtle prominence of the mediastinum hilar shadow, where you cannot be always certain about the underlying lymphadenopathy. Here, cross-sectional imaging modality clearly demonstrates the rim-enhancing lymph node within the mediastinum with central hypodensity suggesting necrosis, which is the hallmark of the tuberculous lymphadenitis. HRCT chest, of course, detects much more lesion than what you can see on a conventional X-ray chest, and also detects a lesion which are not visible on conventional X-ray chest, especially the radiocardiac lung, which is not so well seen, which quite often we pick up in a patient presented with HIV with PUO, where you pick up the tubercle infiltrates in left lower lobe, which is hidden by the hard border. And of course, last but not the least is the selection of the biopsy site. Most of the cases we do mediastinal lymph node biopsies, and depending upon the location of the lymph node within the mediastinum, whether it's paratracheal or subcanal, we can try and approach those lymph nodes percutaneously. However, the hilar or prevascular compartment lymph nodes are not accessed on a CT carotid biopsy. Another important area where we help our pulmonologists to, even when they're doing bronchoscopic and they're doing a BAL or they want to take the aspiration from the bronchi, we try and tell them that which exact bronchus to enter, whether it is upper lobe, apical segment, or posterior segment and all. So the yield is much more when it is guided by the imaging specialist. So when the CD4 cell count is more than 200 actually, so we get more or less imaging appearance of a normal immunocompetent patients, very classical tree-in-bud appearance. That's the central lobe nodule pattern, which is suggests your endobronchial spread, and which is a very hallmark in Indian setting. Number 2 is upper lung consolidations. That also predominantly denote more the upper lobe consolidation. Also, it can show multiple nodules, couple of them which may cavitate. But when the CD4 cell count drops between 50 to 200, you may expect the necrotic mediastinal lymph node, which is best picked up on the HRCT, and also the miliary pattern. However, when the CD4 cell count drops below 50, then the imaging finding becomes very non-specific. You may get the diffuse consolidation in association with the ground glass opacities, pleural effusion, and so on, and virtually is impossible to differentiate or to detect the diagnosis or you can tuberculosis on the basis of CT findings alone. Now, this is what I was talking about, the tree-in-bud appearances. There is nothing but the centrilobular branching structure that resembles a budding tree. And that's very typical, which is seen predominantly in the periphery of the lung fields. And by and large, it suggests the diffuse pen bronchiolitis and endobronchial spread of the mycobacterial infection. So Indian setting, if I see a cavity, or even if we like to say cavity, but if I see a consolidation, a small focal patch or consolidation associated with this kind of the tree-in-bud appearance of nodules, it's pretty suggestive of the tuberculosis. And there's one such example in the upper lobe. You can see that the axial and the condylar reconstruction clearly demonstrate the branching pattern of the central bud nodules, which resembles tree-in-bud appearance. Other patients where you can see the CD4 cell count is around about 78 or so. This X-ray chest showed kind of bilateral haziness and all that with upper lobe some kind of ill-defined shadows, not been able to define much on a conventional X-ray chest. But when we did the CT scan, you can see that very fine nodules which are seen, which is kind of giving rise to the appearance of a ground glass opacity. But the lower down sections clearly show the small nodules, which shows a little bit of branching pattern. So here it is slightly more subtle finding. It's more of a ground glass along with the central bone pattern. Once again, confirm the diagnosis of tuberculosis. This, of course, you don't need anything more guesses. It's very classical appearance. When you look at such picture, it's a classical diagnosis of miliary tuberculosis. And this is, of course, is a very commonly we encountered imaging findings on the CT in a patient with the tuberculosis. You see a small nodules which cavitate. Also, you find surrounding central lobular nodules. In the left upper lobe also, you see some similar nodules also. And in the lower down section, you see some focal patch of consolidation. So all these findings contributes towards the final diagnosis of TB. It's a very interesting patient, young patient who was HIV positive for more than 9 months, not started on ART, presented with the fever, which was lasted more than 3 to 4 weeks, and he was labeled as a pyrexia of unknown origin. His routine investigation included X-ray chest, sonography of the abdomen, was reported to be completely normal. His lab investigation was absolutely inconclusive except for mildly elevated ESR. Since we could not find any underlying cause, the treating physician requested for a CT of the chest to look for any occult lung pathology. This is the contrast enhanced CT scan of the chest, and what you find over here, this is the enhancing the ascending aorta, that's the superior vena cava. This is a descending aorta. This is a trachea in the center, and you see two discrete nodules, one in a prevascular compartment and one in pretracheal compartment. They are enlarged mediastinal lymph nodes. Now, one lymph node which is located in pretracheal is measuring more than 1.5 centimeter in a short axis dimension. When I say short axis means whenever the lymph node you see that, you always try and take the measurement which is in a short axis, not in a long axis, and that's what we give as importance in the CT findings. So your short axis dimension is 1.5, long axis should be more than 2.2 centimeters. Such a big lymph nodes were not picked up on conventional X-ray chest. And what is the reason for that? If you see carefully, all these enlarged lymph nodes are within the confines of the mediastinum. It is not extending beyond the superior vena cava. So when you go back to the X-ray chest, it doesn't cause any mediastinal contour abnormality, so it will go undetected on conventional X-ray chest, but because of the cross-sectional imaging modality, it will be readily picked up. So remember one thing, normal X-ray chest in HIV-infected patient with a kind of constitutional symptoms with a high index of clinical suspicion, I don't think can exclude the diagnosis of tuberculosis, and I think HRCT would be absolutely recommended. This is one more such similar example of an extensive necrotic mediastinal lymphadenopathy. The hallmark of the disease is that most of the lymph nodes shows peripheral rim enhancement and central hypodensity, and that's necrosis, kind of is suggestive of a diagnosis of tuberculosis. There's two different patients. The top row has got one patient, the bottom row is another patient. Both these patients, the CD4 cell count in the range of 50 to 100. The first patient on top, which is on top two rows, shows the diffuse ground glass opacities and all that. And believe me, when you look at this, there is no way one can say that this is tuberculosis. In fact, when you see this kind of diffuse bilateral ground glass opacity, the first thing which comes in your mind is PCP. And the fact is that we would certainly recommend our clinicians to go and do a BAL, and on a bronchial alveolar lavage, it was confirmed to be a PCP. But the case in the bottom two cases where you see a confluent areas of consolidations along with some kind of a central lobar nodules and bilateral pleural effusion, this patient turned out to be tuberculosis. So you can see that as the immunosuppression increases, that when degree of immunosuppression increases, when the CD4 cell count goes down, you get a combination of the imaging findings, and it becomes at times tough to differentiate one from the other. And their tissue diagnosis, sputum examination, and the bronchial alveolar lavage will be extremely important. Now, this is one more slide just to show that how we can do the percutaneous CT-guided biopsy of the subcutaneous lymph nodes whenever we are in doubt. And also, this is the one on this picture I want to show a little more. This is called minimum intensity projection picture on HRCT chest, where we can try and highlight the bronchial anatomy. As you can see that I can see trachea, right left bronchus, and upper lobe, modal lobe, and lower lobe bronchi pattern. So if one of the bronchus connecting with the cavity, one of the nodules over there, we'll tell our pulmonologist to go and take the sample from that bronchus by super selective catheterization and then take aspiration. That will increase the yield of the biopsy material. Iris, everybody knows about it. The most important thing is that in TB iris, you can see that the exaggeration of the existing lesions or new parenchymal lesions. One such case I would like to discuss over here. That's one patient who had come presented with the classical presentation of the patchy consolidation, little bit of the ground glass attenuation, small central lobar nodules and left lower lobe, a typical kind of imaging findings in HIV-infected patient with the constitutional symptoms. We thought of a tuberculosis. Patient put on anti-TB treatment. 10 weeks later, the scan was done, which showed almost near complete resolution of all the lesions. Patients put on the ART later on, and you can see that at 2 months later, almost 8 weeks later, you find totally a new lesion coming up here, and that is completely away from what we had seen the location of the lesion earlier, and that's the central lobar nodule. So you do see this kind of the iris manifestation on the CT chest. Also, you can see a little bit of fluid in the fissure. This is under the horizontal fissure. You can see the little bit of fluid there. Now, coming to the extrapulmonary tuberculosis, we are talking about the abdominal TB. We are talking about central nervous TB and TB of the bone marrow and joints. This is one patient who had presented with the pain in abdomen, fever, loss of weight, and initial sonography of the abdomen picked up the lymph nodes in the abdomen. And on the basis that the possibility of the tuberculosis abdomen was suspected, however, they wanted more clarity, and hence we did the contrast enhanced CT scan. Here, the CT scan done at the level of the mid-upper abdomen. You see the liver, spleen, and you can see some small focal sub-centimeter size hypodense focal lesion in the spleen. Also, you see some amount of necrotic lymph nodes in perigastric and peripancreatic region. The lower down section shows now much more extensive necrotic lymph nodes in paraortic and paracaval region, and also some more lesions into the spleen. On a coronal reconstruction, which is a very extensive, this is a kind of a classical imaging finding of abdominal TB, but it's such an extensive paraortic and paracaval lymphadenopathy, and the spleen is studded with the hypodense granulomas. In our practice, in our Indian setting, though liver and spleen both can be affected by tuberculous granuloma, we have seen more involvement of spleen than the liver. And in fact, when you see a lesion like this, believe me, even if I am not aware about the HIV status, I would certainly alert my clinician that if the HIV status is not known, I would certainly say that please go and do the HIV testing, because this could be HIV positive patient. We don't see this kind of so much scattered granuloma immunocompetent patient. And the spleen is the kind of the major target for HIV granulomas. Another patient, more or less similar findings, and here you can see that there is a pleural effusion, there is a necrotic lymph node in peripancreatic region, once again a kind of splenic granulomas. In a pelvic section shows fluid in the pelvis, and also most important, you see small soft tissue between the anti-abdominal wall and the gastrographic bowel loop. That's an omental thickening. So the omental thickening also, can, like the peritoneal tuberculosis, can be easily picked up on a CT scan. Another patient shows the bilateral pleural effusion. Lower down shows extensive lymph nodes in the vicinity of the aorta and IVC, a large lymph node. But compared to the contrast to the WATS scans I showed you earlier, this lymph node, none of them are showing a central hypodensity. There's no caseating, there's no necrotic lymph nodes. And the sections over here show the diffuse thickening of one of the ileal bowel loop. This is called a Hamburger sign, where you can see the lumen in the center and the two thick walls of the bowel. And this is a very classical imaging findings of a lymphoma, because this is a large, non-necrotic lymph node mass, a very thick bowel wall, the involvement. This was a CT scan biopsy was carried out and is proved to be B-cell non-Hodgkin's lymphoma. Coming to a CNS, is a major target of HIV. Clinical findings are non-specific and often unable to distinguish between the vast array of the neurological disease process and AIDS. A large part of the diagnosis process still relies on imaging because the brain biopsy is not an easy option in this group of patients. MRI is the modality of choice and more sensitive than CT scan because of excellent soft tissue contrast resolution, excellent gray white matter differentiation, and ability to pick up the lesion at much earlier stage than a CT scan. Two focal patterns have been clearly seen. In the CNS tuberculosis, either you see the parenchymal involvement or a meningeal involvement. If it's a parenchymal involvement, you see the tuberculoma or tubercle abscesses. But in 1/3 of patients, you can see that hydrocephalus, basal meningitis, and cerebral infarction secondary to the vasculitis. This is what we commonly encounter in TB meningitis patient. This is a pre-contrast CT scan in this one such patient, where you see the low density areas in right temporal lobe and a basal ganglia, with a finger-like projection is nothing but a vasogenic edema. Following contrast, look at the picture changes so dramatically. You can see the enhancing basal exudates and sylvian fissure. You can see in the intrahemispheric fissure along the middle cerebral artery on both sides, antehemispheric fissure, and in addition you see tiny sub-centimeter size nodular enhancing granuloma scattered in both cerebral hemispheres. So this is a classical example of TB meningitis with the multiple tuberculomas. You also see tuberculomas not only in the brain, in the cerebellum and the cerebral hemisphere, which usually at the gray white matter interface, they're usually less than 1.5 centimeter in size. They enhance beautifully, they will enhance brilliantly. They can have a nodular enhancement or ring enhancement, and also it can involve the spinal cord. You can see that one is in the cerebellum and one is spinal cord. Spinal cord, whenever you see a lesion, the biopsy is not an option. This is a different patient who presented with the bilateral low limb weakness, and that shows a nodular lesion into the mid-dorsal cord, which appears hypointense on T2 weighted images. There's a lot of hyperintense signal in surrounding cord parenchyma. That's the cord edema. On T1 weighted images, you can't identify the lesion at all. After putting a gadolinium, that's MR contrast, you get the lesion enhances beautifully, and that's the intramedullary tuberculoma. Believe me, when you see a picture like this, we are almost 99% certain about the diagnosis when you find T2 hypointensity of the lesion on the MRI. Because we believe that the caseation within the tuberculoma gives a hypointense signal on T2 weighted images, and that's a hallmark, and we have proved n number of times. These patients are put on anticox treatment, and then it shows complete resolution. This is one such example of the large tuberculous abscesses. There's one interesting case. This patient was a young patient, HIV positive patient, presented with the convulsion, right-sided focal convulsion. It showed a focal lesion into left parietal region, fairly large lesion, and we were deciding whether are we dealing with some kind of granuloma or the neoplasm. What kind of neoplasm? Is it the glioma or the lymphoma? Lymphoma obviously is more common than a glioma. We did the MRI, there's a CT scan, and what the MRI shows, on T1 weighted image, a lesion appears almost isodense with the rest of the brain parenchyma, but on T2 weighted images, the lesion appears absolutely dark. And this is something a hallmark for a tuberculoma. In spite of the lesion being a 2.5 to 3 centimeter, which is not commonly seen in the Indian setting, still we strongly believe that this is the giant tuberculoma, and we tell our clinician not to intervene, not to take the biopsy, and we put on the patient the anti-TB treatment, and 4 months' time, almost 60% of tuberculoma was resolved. So we have time and again we have shown that the MRI has a signal intensity characteristic which can be very much diagnostic of tuberculoma. This is something which another patient was presented with a predominantly headache with no focal neurological signs, and it shows a lot of edema and basal ganglia, and following contrast you saw an ill-defined ring enhancement. Am I looking at the tuberculoma and basal ganglia? Remember one thing, in Indian setting, in spite of the tuberculosis being so common in India, if I see a lesion like this in a basal ganglia, which is so ill-defined, which has got disproportionate edema, I would certainly diagnose this as a toxoplasmosis. Even in Indian setting, initially people believed that toxo is maybe seen in the Western and other African countries, but not in India. But now we have proved that the basal ganglia is the most common site for toxo. And whenever there's a doubt, we tell our clinician to start with anti-toxo line of treatment, because that's only 3 to 4 weeks of treatment of sulfadiazine and trimethoprim, and repeat the imaging study. And it's a therapeutic test, because you repeat the study, and if it shows even the 20, 30, 40% of resolution, we know we're on the right track. So this is the case of a toxoplasmosis. Another very important patient, HIV positive patient, came with a right-sided focal lesion. This is basically the T1 weighted images. You see some ill-defined T1 hypointensity next to the fourth ventricle in the middle cerebral peduncle, and you see it in left frontal cortex. This patient had a convulsion and with the slurring of the speech. T2 flare images shows the lesion better. Now we can see the hyperintensity in the middle cerebral peduncle and left frontal lobe over here, but still we do not come to any conclusion, because this looks like probably some kind of edema surrounding the lesion. We put the contrast, and we see that there's a ring enhancing lesion in left frontal lobe, and then coronal scan shows a lot of dural enhancement. So the lesion which is at the periphery in the gray white matter interface with the associated dural enhancement, we're pretty sure that we're dealing with some kind of granuloma like tuberculoma. But the most important thing, what you see here, the lesion in the close to fourth ventricle did not pick up any contrast. Neither it showed any kind of mass effect on adjacent fourth ventricle. Am I dealing with some kind of evolving tuberculoma? Unlikely to be there. So remember one thing, this patient's CD4 cell count was 60 at the time of his presentation of this thing. So we strongly suspected as the progressive multifocal leukoencephalopathy. So basically this is the case where we have the combination of two diagnoses, progressive multifocal encephalopathy plus tuberculoma. PML normally affects the parietal lobes, subcortical U fibers, but another location of PML is we see more common nowadays is posterior location in brachium pontis, that's middle cerebral peduncle. This is a multifocal, this is the kind of the COX that we see nowadays in the HIV and the immunocompetent patients as well. T1, T2 and the post-contrast dorsal spine images shows two adjacent vertebra, marrow involvement with contrast enhancement with also near complete involvement of the disc. So basically, you see on a coronal images, you see a large psoas abscess, and all that, and a lot of enhancing in prevertebral soft tissue and all. So this is the classical case of an infective spondylodiscitis, and in the Indian clinical setting, this is tuberculosis. Whenever you see this picture like this, we are very sure about this is going to be a port spine. We also see nowadays a lot of multifocal COX, and you can see this T1 and T2 weighted images shows multiple focal marrow signal involvement, not involving the two adjacent vertebra, but even distant vertebra in a 67 years old female patient. We saw a lot of other osteoporotic compression fractures as well. T2 shows marrow signal, post-contrast shows multiple enhancement, and this is another example of multifocal tuberculosis. Prior to the HIV status, whenever we see multiplicity, we would suspect either multiple myelomas, lymphomas, metastasis, but now we know that if it's associated with prevertebral paraspinal abscess, obviously we are dealing with multifocal tuberculosis. And last one or two slides, this is just the SI joint tuberculosis. This, of course, by no way I can say that this is SI joint tuberculosis. This is bottom two are the CT scan, shows the sclerosis of the iliac and sacral bone with the near complete erosion of the subchondral erosion of the SI joint. And MRI also feels some altered marrow signal over here. This patient, we were not too sure about it, but we strongly suspected since he was HIV infected. So we went in and did the CT guided bone biopsy, and that proved to be tuberculosis. So basically, to summarize, imaging plays a very important role in the diagnosis of the tuberculosis and HIV infected individuals. There are certain imaging findings which certainly help us to narrow down the differential diagnosis or clinical diagnosis. And in the absence of tissue diagnosis and inclusive lab results, imaging remains the only basis for starting empiric therapy. Thank you so much.